Well, good evening. I'm Kathleen Digree, and I'm here at the University of Utah Headache Clinic and Headache School, and I want to welcome everybody tonight. And tonight we have a special guest. We have two special guests. We have Dr. Laura Czajkowski and Dr. Chris Jones. Dr. Czajkowski is a professor of psychiatry and works in the sleep clinic, and Dr. Jones is a professor of neurology and used to work in the sleep clinic but now does mainly research, but he is here to answer any questions about sleep. If you have headaches and people have sleep disturbances, and we have a lot of people who have not only sleep disturbances like insomnia, but we have many patients also that have sleep apnea that can actually cause a lot of headaches. And so tonight, this is a time where we hope to unravel mysteries of sleep and headache in some ways, and at least understand some of the problems that people have with sleep, because it's so important for a healthy brain and for headache control is to have good sleep. So I think Laura Czajkowski is going to start us off. So I'm going to give you the microphone here, and if you would like, do you want me to help push slides forward, or are you going to be okay?
I can do this.
Okay.
Is this okay? With the sound?
Lauren, can you hear the sound?
Okay. Well, first of all, thanks for having us here. And I hope we can give you some information on headaches and sleep. And really what I want to talk about is insomnia in terms of it being a very common form of sleep disturbance and headaches. As a matter of fact, it's the most common. And that it's associated with both chronic migraines, chronic tension headaches, and tension headaches in general. And then we also want to talk about obstructive sleep apnea and headaches. And in addition, we want to talk about how behavioral interventions in terms of improving your overall sleep quality and the evidence that it can decrease headache frequency and symptoms. And we're going to do this very quickly. So, insomnia, this is one of the hallmarks, is that we're always striving to sleep when we can't sleep. And once you start striving, you're not going to sleep. I mean, that's just it. So with chronic tension type headaches, we know that that's the most common form of primary headache, and that if we have decreases or increase in sleep disturbance, so if we have shorter sleep, we have fragmented sleep, or we have too much sleep, it can trigger headache. We also know that having insomnia or a sleep disturbance in general is also associated with an increased risk of chronic tension headaches. And in addition, insomnia is very common in chronic tension headaches. So insomnia in general, if you have it, now you have an increased risk of having tension headaches. So we have almost a bidirectional interaction between headaches and sleep disturbance, which hopefully we will point out. Now, there was a recent study, and this was a population study, looking at the prevalence of insomnia among individuals who had headaches and among individuals who didn't have headaches. And if you see, because I forgot my pointer, in the first bar, I mean, the percentage which was much lower than the second and third bar, which include individuals who have tension headaches without migraine or tension headaches with migraine. So there was a very significant difference between these groups. So this is a real and a very significant problem. So we also know that insomnia is the most common sleep complaint in migraine headaches too. And with an increase in migraine frequency, we're going to have an increase with sleep disturbance, poor sleep quality. But it works in the opposite too. So if we have poor sleep quality, we have an increase in vulnerability to migraine frequency. So what contributes? Well, if we're sleep deprived, if we sleep too much, And if we shift the timing of our sleep, all of these factors will contribute to a possible increase in migraine headaches. We also know that if you take a nap, okay, to compensate for some insomnia, we can decrease migraine headaches. But there's also going to be a caveat to that. What happens to your sleep disturbance the following night, okay? So, you also have to think about, okay, I just said that sometimes taking a nap can help with migraines, but we also know that taking a nap can also increase migraines. And people have migraines after headaches, after a nap. So, it depends upon just how your body works, okay? All right, so the bottom line there is that headaches and sleep go together, okay? Both are associated with stress, okay? When you're stressed, you know, you don't sleep very well. When you're stressed, your vulnerability to headache also increases, okay? Fatigue, you get tired with both if you're not sleeping and if you have headache. And it can lead to shorter sleep and poor sleep habits. And what I mean by those are the things that we try to do to compensate for either our headaches or for our poor sleep, okay? And what happens over time with that. So if you take a nap, it may indeed decrease your headache, but what is it going to do to your sleep that night? And it may decrease your sleep that night, or the quality or the depth of your sleep may indeed change so that you have an increased vulnerability to headache the next day and increased sensitivity to pain. Okay? Same thing. So I can have people who sleep for 15, 20 hours and, you know, I have a headache, have to go to sleep, but then the next day they still have a headache. Okay? All right. So, when we look at a behavioral model of sleep, we're looking at two primary factors. And one is called the homeostatic process, or process S. This is our sleep drive. This is the pressure to sleep. And the other is the circadian process. And this refers to the biological timing of our sleep, when naturally we feel like sleeping. So some of us, not me, are morning larks. Other individuals are night owls. And we all vary somewhere on this continuum, okay? This is just for your information. So when you look at this model, in the left-hand side of the slide is during the day. And your sleep load, or that process S, is lowest when we get up, because we just finished sleeping, right? And it increases as the day progresses. The circadian alerting signal as we wake up also increases. But by the time we get to the evening, what happens is that melatonin is secreted, and then the circadian alerting signal is thought to decrease, which allows the sleep load, which is very high then, to come on, and we sleep. Okay? So, let's get to this. So what's insomnia? So insomnia is when you can't fall asleep, you can't stay asleep, you wake up too early. It becomes chronic when it's present for at least 3 months, and you must give yourself an opportunity to sleep. You feel not great the next day, you're tired, you may be irritable, you're not as alert as you want to be. And it occurs at least 3 or more days a week. It frequently occurs with sleep disorders, with depression, anxiety, fibromyalgia, chronic pain complaints, a variety of disorders. But it needs to be treated as an independent disorder. It is not secondary to, it's its own disorder. Okay. What are the causes of insomnia? Some of us are just predisposed to it. So, almost everybody in this room are female. So that means we're more predisposed just because of gender, okay? So there's predisposing factors, precipitating, meaning something happens that we deem as stressful, and then we develop these behaviors that we think initially may be really okay to do, but over time are counterproductive. So this is our model of insomnia. So with the predisposing factors, besides female gender, these are individuals who have a tendency to be a little anxious. It's hard to turn off your brain. You have a tendency to worry, be a little bit anxious. And then something happens that's very stressful, okay? You can't sleep that night. Okay. Well, the next night it happens again. Oh. Well, then we start to do some other types of behaviors to try and compensate. So I'll have a little caffeine, okay? Or I'll take a sleeping pill, or I'll go to bed a little bit earlier. And you may get some immediate benefit from that, but over time it becomes counterproductive and we develop chronic insomnia, okay? So we talked about those. Another component that is important, and it's going to relate to when I talk about couples, is our feelings of attachment. And this is something that develops in childhood. But it's our feeling of safety and comfort at night. So you think about individuals who have trauma histories, all right? It's going to be sometimes very difficult to feel safe at night when you hear, let's say, certain noises that remind you of something. So this is very important when we're looking at sleep in general. Okay. In terms of perpetuating factors, we know with some of these poor habits that we get into that we have variability then in our night of sleep, not only with our total sleep time per se, but with the number of awakenings and how many sleep episodes that we have and how long they are. We then also put incredible pressure on ourselves. We need to sleep because I have to perform the next day. Okay? So that anxiety and that anticipation of whether I'm going to sleep is certainly going to interfere with sleeping, because again, what we're doing is striving to sleep. Okay? So sometimes what we do is we sleep in a little bit later. Okay? Sometimes we try to go to bed a little earlier. But what happens when we do that over time is that we change some of the circadian timing of our sleep. So we also know that the variability with our sleep times, okay, can contribute to the headaches. So what are these maladaptive behaviors? So there's naps, there's caffeine, there's alcohol, there's sleep medication. And if we use caffeine and we start using caffeine in the middle of the afternoon or in the early evening, it may indeed interrupt when we're able to fall asleep. And we have a decrease in our total sleep time. If we take naps, we're going to have an irregular sleep pattern at night because it's going to interfere with that sleep load now. So it'll be more difficult to fall asleep and the depth of our sleep may be impacted. We also start to pay attention to anything in our environment that may indeed interrupt our sleep. So if your daughter is practicing the violin downstairs and it becomes a little screechy, you go, oh, what kind of night am I going to have? Okay. Now, sedatives, and some of the sleep medications, and Dr. Jones can talk about that, do have detrimental effects, especially over time, and we need to be careful with that. Okay. So, major contributors to insomnia: hyper-alert brain. We just can't shut down. There may be a mismatch between our biological sleep rhythms and the demands of our solar day. We engage in these counterproductive behaviors, and then we come up with these beliefs about our sleep. I will never be able to sleep again without medication. If I don't sleep tonight, I will have a migraine headache that will be 10 out of 10, and it will last all day. Okay? And then we have these habits that also maintain the insomnia, whether it's irregular bedtimes, we're drinking alcohol too late, we are using the bed for other things but sleep, okay? Our bed becomes our desk, has our computer, it has Facebook, it has everything, okay? So, what we know is some of the coping behaviors for headache now can precipitate and perpetuate the sleep disturbance. So what I'm talking about specifically can be like taking a nap, okay? The disruption in the sleep physiology, and I mean the depth of sleep, will increase the propensity for your headaches. So there is an overlap so that the headache and the insomnia transform and perpetuate to chronic headaches now. Okay? So we have to treat both. This is the bottom line here. So sleep is reinforcing in eliminating the headache, but it can lead to disruption of sleep-wake. And we know that at least 81% of individuals with tension-type headaches go take a nap as the best strategy that they can use to eliminate the headaches. Okay, so this is a complicated model of headaches and sleep. But if you start from headache onset, and it depends upon what you do, and contingent upon whether it's medication overusage, whether you're taking a nap, drinking caffeine, it's going to impact your variability of the duration of your sleep-wake pattern that can lead to chronic insomnia, and then that leads to dysregulation of the timing of our sleep, which can also contribute to a decrease with slow wave activity of sleep, increase your pain sensitivity, decrease melatonin onset, and we have a circle now. Okay? So we need to intervene in all of these areas. So how do you get enough sleep? Now, if I knew the answer to that at 100%, I would be a very wealthy person. Okay. Okay, the gold standard of treatment for insomnia is called cognitive behavior therapy of insomnia. This is the first line of treatment. It targets the cognitive and behavioral factors by changing some of our sleep habits, correcting our beliefs about sleep, and developing coping skills and strategies to decrease that level of arousal. So we have to keep in mind that we're targeting the specific factors that interfere with going to sleep. So for example, if somebody is going to sleep at 8 o'clock because I have to get enough sleep so I don't get a headache, but their biological readiness for sleep isn't until 10 p.m. and they're just laying there awake, what have we accomplished? Nothing. So what we're targeting then is their bedtime. So it's more in line of when they would naturally go to sleep, okay? This is based on a learning model, okay? There is efficacy for this. If there's going to be one component that I want you to just hang on to, it's going to be the stimulus control instructions. This is the gold banner here. This is what we need to do. We'll also talk about sleep hygiene. Everybody talks about sleep hygiene. Sleep hygiene is good by itself, not so great, but we need to talk about it. We have to reduce this level of arousal that we have, and we have to make sure the circadian factors and the sleep load are in balance. And then we have to look at our beliefs. All right, so this is the same thing in terms of looking at our sleep need, that if the urge goes down after we have a period of sleep, it kind of bumps up a little after noon, 2 o'clock or so, and then it starts to go up again. So we want that need to be always going up. But when we do this, it changes it, okay? So I know that napping is important sometimes, especially with some headaches. but we have to do it judiciously too, because we want to look at our whole sleep pattern. Okay, so here it is, all right? We want the bed to be associated with sleep and sex. That's it, S&S. So it's SSS, right? This is what we want, okay. What we have, though, normally, is that the bed becomes associated with worry, thinking, could be arguing, could be eating, it could be making phone calls, it could be looking at Facebook, and everything in the whole wide world. So it becomes conditioned as a place to be awake, and we think we are resting, okay, but we're really not resting because we're engaging our brain, okay? So those wake centers don't have an opportunity to turn off, okay? So we develop these coping behaviors. You think you're getting rest, and we're developing another conditioning history that we don't want. So it's stimulus control. First one, you go to bed when you're sleepy. There's a difference between sleepiness and tiredness, okay? Sleepiness is when your eyes are closing, your head is nodding. Tiredness is when you have that feeling of being depleted and exhausted, okay? So someone, and this is really quite common, you could be in the living room watching TV, reading a book, and your head is nodding, and you're falling asleep. So, oh man, I have to go to bed. And as soon as you get into the bed, it's like a green light goes on, and you're totally awake, okay? That's because of conditioning of all the other things that we do there. And then we stay in bed, I have to go to sleep, and you're trying to sleep. We use the bed for only sleep and sex, and if we're not asleep within 15 to 20 minutes, and this is the hardest thing to do, and I have to do it too, then you get out of bed. You don't continue to try and sleep. But you go to a quiet place where it's dark and engage in behaviors that will decrease that level of arousal and increase our readiness for sleep. Don't nap, and you need a consistent wake time. Okay? So, regardless of whether you fell asleep at 3 a.m., you still wake up at 8 a.m. if that is your time. Okay? That way we'll have enough sleep drive for the following night. Make sense? Okay, sleep hygiene. We know this. Avoid alcohol, caffeinated beverages, tobacco, large meals, and vigorous, intense exercise at least an hour before bedtime, okay? We need the environment to be dark, cool, comfortable. We don't want to be looking at the clock and calculating, oh, 25 more minutes and, you know, it'll be 2 a.m. That's the time I'm always up, okay? We want to avoid naps, and problem solving and worrying needs to be done earlier, okay? Now, if you just do these things, it will help, but it's not going to be effective, okay? We have to look at the cognitive aspect of this, all right? What do we do while we're laying there? And, you know, I love this slide, you know. You're thinking about, you know, who wronged you, what you did, reviewing conversations, you know. You may be thinking about what disease will I get, money, why did I say that? And we do this throughout the night, and it becomes a loop, okay? So, the cognitive aspect of this is addressing our negative thoughts and how do we change them in terms of our sleep and also our expectations. What do we do with this worry? It is hard sometimes when you're so anxious and you're so worried to calm down. And staying again in bed trying to, okay, let me clear my mind. Sometimes that just doesn't work. And we need to get into a different setting. because we get frustrated. You try and clear your mind. Okay, I'm breathing. No, I'm thinking about the budget. Okay, and we need to change settings. And keeping in mind that these strategies are learned behaviors and they take time, okay, to acquire. We have to look at our views related to sleep. I have to have 8 hours of sleep or else I will have 2 headaches this week. Okay. Not necessarily. We have to look at what average total sleep time is for an individual. Okay. We also then engage in behaviors, I call it more avoidance, where if we think that we're not going to sleep, we start to avoid activities that may be indeed more challenging. Like, oh, I better not work on this talk tonight because then I really won't sleep. Or we avoid going to social events because, well, I may not get home in time and then I won't have enough time to sleep. And then if that happens, then, you know, if you don't get enough sleep, then I'm going to get a headache. Okay? So, part of treatment is relaxation. And how do we do that? With a variety of ways. I mean, we're targeting both the brain and also our physical agitation. And sometimes we are really physically agitated. And it's not unusual for me to recommend, if you're that physically agitated, and if, you know, you're halfway strong, then, you know, okay, let's do at least 10 or 15 squats. Okay, and then we start to do more of a relaxation technique. So we could do progressive muscle relaxation, deep breathing, autogenics, mindfulness practices, and meditation. The focus is on trying to down-regulate. And there are a whole bunch of free apps right now that are available to help with that. Headspace, that you can find. There is a great YouTube video, and this is by a neuroscientist from UCLA. His name is Sam Harris, and he does a beautiful 26-minute guided mindfulness practice that can be very helpful. And it's more on breathing, but accepting your thoughts, and it can be very effective. But again, remember that these are skills to develop. Okay? So doing any of these. Now, so do we know that this works with individuals who have headaches? And this was one study that it's very hard to find randomized controlled studies that was looking at a group of individuals with chronic migraine. And the outcomes in general was we had a decrease in headache frequency in the control group, and also in the experimental group, and we had greater decrease in headache severity and disability and frequency in the group with the intervention. So they did a wonderful study here with headache diaries, actigraphy. They had different types of questionnaires related to headache, migraine, disability, in addition to all the sleep measures. And both groups were divided, and there was no contact between them, and nothing was changed with their medical care. So whatever they did for their headaches, you know, they were allowed to do, except for introducing a new medication. And the behavioral treatment group, their instructions were mostly the stimulus control that we just went over. Just go to bed when you're sleepy, leave the bedroom if you can't sleep within 20 minutes, use the bed for sleep and sex, set an alarm, have consistent wake time, and restrict your time in bed to your total sleep time. So what that means, plus 30 minutes. If somebody was in bed for 10 hours and they only slept for 8 hours, you would restrict their time to 8 hours and 30 minutes, okay? Trying to compress their sleep. So that was that group's instruction. The other group, they had to eat dinner at a consistent time, do some acupressure, record liquids consumed, do stretching, range of motion, and have some protein, okay? So that was their control group. So what did we find out? So the circles is the group with the CBTI, and the triangles was the control group. And if you look at it, I mean, the trend is for both groups, you know, to have a decrease in headache frequency. And the control group at post-treatment, you know, that group reduced by 36% the frequency of their headaches as compared to the CBTI group, which was 26%. However, when you went post-treatment in that follow-up, there was a change where the CBTI group from baseline decreased the number of headaches that they had by 49%, okay? And the control group then was at 25%, okay? So there is some efficacy here, but we need more studies, there's no question about it. Okay, then I get to talk about marriage and sleep, right? So if we think about the bed partner, we don't include them enough in our assessments with sleep and possibly with headaches too. But, you know, about 60% of us sleep with a bed partner, and 30% of us, if they snore too much or there's a lot of activity going on, may sleep in separate bedrooms. But what we find out is for individuals who sleep in a separate bedroom because their spouse may snore, that their sleep, if we measure on a sleep study, looks great, but they rate their sleep quality as not great because they want to sleep with their partner, okay? We also find out that, you know, we kind of sleep like each other when we're together for a while, so our pattern of awakenings is very similar, okay? So we kind of get together with our bed partner in terms of our movement and when we wake up. Okay, so what impacts our sleeping with our partner? Our attachment, and we know that if there's a fear of, you know, somebody's going to be leaving or that we tend to be anxious, we're going to have greater sleep difficulty. If you're in the process of a divorce, we're going to have sleep difficulties. If there's conflict, there's sleep disturbance. So, you know, keeping that in mind. Now, individuals who have, let's say one of their partners goes away on a business trip and they have an anxious attachment style, they get nervous, they're going to have poor sleep when their spouse goes away. On the other side, individuals who have a very solid and secure attachment with their spouse will not have reduced sleep, but they will say that their sleep quality would be better if their partner was there. So marriage in general and having a partner promotes good health via social control, okay, where individuals are monitoring for their spouse's health, whether it's their diet, exercise, it's time to go to the doctor, okay? Women do this better than men do this, okay? So we need to think about sleeping together, all right? Partners help in the diagnosis of sleep apnea, on the impact of knowing what is happening with the OSA on the partner, because we learned that you're keeping me up, and also on the relationship, and the partner can influence adherence to CPAP. And this is important in terms of headaches too, and it's also important in terms of insomnia. Do you want to jump in now?
I'll talk about that.
Okay.
It can be a very big deal when one partner thinks the other partner has horrific, medically dangerous snoring and breath holding, and the other partner is asleep and has no idea that's going on.
So we know that, you know, the bed partner is more likely to report the symptoms of their spouse who snores, but they're also more likely then to have insomnia and poor sleep quality. And if we don't treat, there's a negative impact on the relationship in general. We know if we treat, okay, it improves the sleep quality of the spouse. It decreases their apnea-hypopnea index. It decreases arousals. It improves sleep efficiency. And we have improvement in sleep quality and daytime sleepiness. It improves relationship quality, marital satisfaction, fewer disagreements. So we have all this improvement, but we don't like to use it. We just don't, okay? I mean, we have non-adherence with this. Well, why? Okay, why? Well, first of all, we have to figure out, you know, what does non-adherence mean? And it means the behavior that you and your provider agreed upon. So you say, okay, we want you to use the CPAP, and we want you to use it for about this amount of time, and they go away thinking, well, I'll use the CPAP just for, 2 or 3 hours. That isn't compliance or adherence, okay? So we all have to be on the same page. And we have to keep in mind when we're trying to increase adherence that it's an interaction, okay, from things that don't change, like our gender, all right, to things that do change, like our beliefs, our attitudes, and our motivation about this whole process. So, like Dr. Jones was saying, if the individual with sleep apnea is asleep and snoring away, they may just think they're just sleeping fine and I have no problem with this. So I don't need this. What are their beliefs? Do they think this is going to work? I don't want to wear this. This isn't going to work. What is their perception of, if I don't treat this, what will happen? No, nothing's going to happen to me. I'm fine, okay? Do they have confidence in their ability to do this? What about your image? I mean, do you want to look like Darth Vader? And many of them feel, this is the way I look, okay? And especially women. What's the impact on my relationship? How's it going to change our pre-sleep ritual? And it has to be considered in the context of what's going on in their life right now. So, I mean, if somebody has insomnia in addition to sleep apnea and then headaches too, I mean, they're not going to be thrilled with this recommendation from the beginning. And then we have to deal with the equipment itself. You know, sometimes it's hard to get a seal, and then you turn, and then it falls off your face, and then there's air leaking, and there's noise, okay? But what do we know is that, first of all, if you're married, you know, you have a partner who's invested, that, you know, you kind of adapt to it a little bit more quickly. And that the individual who has the sleep apnea may just do it because they know that their partner's sleep has been disrupted, okay? We also know, I mean, just living with someone makes a difference in how many hours that you'll use it, okay? So, just going into a different bedroom isn't going to help necessarily, okay? Because you may indeed still hear them, okay? So we're looking at, well, what is it in that relationship that helps, okay? What does it mean? What does support mean, okay? And support in this context is encouragement, and it's collaborative, as opposed to nagging or being critical, or what's going to happen if you don't use it, we're going to lose this money, etc. Okay? So it needs to be collaborative and gentle in some ways, okay? And if we do, then we find, again, there's a decrease in sleepiness, and the relationship improves, and there's a decrease in marital conflict. There's also an increase in intimacy, okay? And this was a study that was done here, as a matter of fact, okay? So again, we have to look at the nature of the support. So many times at the sleep center, people get referred because their partner says, you got to go in, okay? You go in there, why are you here? My spouse made me come in, I don't have a sleep problem. Okay, so you have to own the problem yourself, and if you do, we'll see better adherence. Okay, this was the same study, and again, if there was negative pressure to use the CPAP, there was poor adherence with it at 3 months. So, marital conflict predicted lower adherence, and there was a trend for a positive relationship with perceived collaborative spousal environment with CPAP usage. Okay, so this is a newer study that was just published a month ago that to facilitate CPAP usage, we need to have the partner there from the beginning. We need to work together and understand how this whole thing does work. We have to look at, are the benefits perceived as beneficial to us? What is the motivation? And we need to have ongoing support where the partner is coming to multiple clinic appointments and not just the first clinic appointment. Okay? So in summary, so OSA is associated with poorer partner sleep, in addition to the patient's sleep, poorer marital quality. Having a partner influences adherence. Good partner support facilitates it. But we have to watch how we're doing the support. So, make sure you go to appointments with your spouse. Identify how we can help each other. And be aware that your support within the relationship, and not only within whether you're using CPAP, but throughout the day, the contact that you have with your partner in terms of interest in what's going on in their life will also impact that night in terms of their adherence to sleep. So, I am done with my part.
Well, I have some questions for you.
Yeah, and so maybe could you get up and use the microphone with Dr. Czajkowski?
And I am under time. Okay.
So, Dr. Czajkowski, one of the more helpful hints I got from you, which I guess is maybe obvious to a lot of people, is, if I remember this correctly, that a very common source of daytime intramarital stress is the money. It's about the household budget and the fact that it might be going down. And whose fault is that? This sounds like a loaded conversation that's not going to end well unless both parties are into this. Do you think that this is as common as I've been told it is, in terms of stress that could influence insomnia, for example, and sleep quality?
Yes.
And if so, do you have any ideas, thoughts about how to manage it better?
I mean, certainly stress within the relationship associated with lots of environmental factors, whether it is money, whether it's how we're raising our children, is going to have an impact on insomnia. And the question is, when do we have these discussions? And having the discussions prior to bedtime is not a wise choice.
So morning.
I would say at least before, 7 o'clock in the evening, definitely.
Yeah.
Yeah.
And so another aspect of this that maybe sleep medicine has to wrestle with a little bit more than other aspects of medicine is that a lot of what happens when at night when you're asleep is that you can't remember what happened. It's very difficult to remember things that happened when you were drowsy, groggy, half awake, So if my wife asked me, she said, you went to the bathroom 3 times last night. And I said, no, are you kidding? I mean, it's almost like saying that I snore, and I would say, no, I don't snore. I've never heard myself snore because I'm asleep. So there's, I think, a real profound difference sometimes in perceived reality. If you could, can you talk to that point for just a minute there?
It is so common that partners have differences in the perception of that night. So whether it's how many times somebody went to the bathroom, or someone with insomnia saying, I was up the entire night and, didn't get a wink of sleep, and the bed partner saying, you were snoring logs. What are you talking about? Okay. And the bed partner saying that, no, I was up because I heard the cat next door go out, and then John down the street, who comes in at 3 a.m., that garage opened. So there are different perceptions. And sometimes, especially with our insomniacs, their level of sleep is compromised, and they are aware of many of these things because they are not able to turn off part of that wake brain. Do you want to talk some more about this?
Yes. So I'll never forget the time when I was interviewing a patient, a male, who probably had obstructive sleep apnea. And if there's time, I can chat a little bit about risk factors that you could, aside from sleeping with them and hearing them stop breathing and so on, some risk factors for sleep apnea. But I was talking with this big guy. He's male. His neck is like this big, and he's got sort of bags under his eyes. And I'm thinking, if this guy doesn't have sleep apnea, I don't know who does. And he said, yeah, it doesn't bother me, and yeah. But then the wife sort of is, she's sort of moving around in her chair and rolling her eyes, and I'm starting to think, something's going on here. And she said, well, George, you're not, paying attention to me. When was the last time we, had some personal time together at night? And he goes, and that's when I started thinking, yeah, obstructive sleep apnea can really rob men of sexual function. And I mean, even with a lot of stimulation, they may not be very functional if they are really exhausted from obstructive sleep apnea. And I think that is, right from the get-go, Dr. Czajkowski has a tough job, because oftentimes, the wife may be exhausted because she has insomnia, and he may be exhausted mentally and intellectually because he has obstructive sleep apnea. So I think sleep medicine really has some tough challenges. If you could maybe just agree with me on that one.
I'll agree with you 100%.
Or something you want to add?
I was thinking, your example, and then in addition, if you have the person, we have, like CPAP machines in stereo. So we have both partners with obstructive sleep apnea and insomnia. And it becomes very challenging then when one part of that dyad decides, well, I don't want to use my CPAP machine anymore. And it becomes behaviorally very challenging to engage them in looking at treatment options.
And do women get sleep apnea too?
Oh,
Yes.
Yes.
And I mean, it is oftentimes a more feminine version of it. But remind me to get back to this. I think another thing Dr. Czajkowski taught me, along with some of your colleagues, was that by the time the sleep apnea patient or someone were in the living room, in the waiting room, the physician is looking out in the waiting room and says, well, that one's got obstructive sleep apnea and she's probably got insomnia, but before they get to the doctor's office, and there I am, and there's the patient, and there's the spouse, and what I never knew, what I never appreciated, was that it takes 3 or 4 months to get an appointment with a sleep medicine physician, and it took another 3 or 4 months just to talk him into coming to the sleep center, so that by the time I was seeing obstructive sleep apnea patients, he and she had been arguing for half a year about whether he has sleep apnea, and now the doctor is going to say who was right and who was wrong. And it never occurred to me what the psychological risk I was running in actually saying, you know what, you got a big neck, you got a recessed chin, your nasal airway is obstructed, your wife clearly describes crescendo snoring, you have a loss of libido, your boss at work is coming down on you because you're taking naps, and you had 3 close calls at driving a car through some tricky intersections here. So they've been arguing about this for a long time. And now the physician is supposed to, like the judge, in a court of law, say, you were wrong, you were right. and so I never really thought about how to manage that. Are there some simple things that you can tell providers, sleep medicine providers? Or do we just be more aware that probably the research that you did show that they've been arguing for quite some time?
Right.
Yeah.
And at this point, I mean, because this does happen, because you'll see one of them go, I told you so. And I'm there, oh. And I try and reframe it. This is a couples issue. This is something that has been present for a long time. The important part right now is that we are addressing it and how to, maximize your sleep and your comfort for both of you. And, we don't need to know who is right and wrong. That isn't the issue now. And if I can engage them in that way, we may be able to move forward.
Yeah. We might want to see if our audience has any questions, too. And just repeat the question when they have it. We remember, one of the goals is you can't leave with a question, right?
I do have a question. You mentioned earlier. You mentioned earlier that you're not supposed to take naps, and you're supposed to get up at the same time if you haven't been sleeping, and you're not supposed to go get in bed unless you're sleepy. And okay, so if you didn't sleep well and you woke up at your regular time and you don't feel like you're going to make it through the day, what are some positive things that you can do to make it to the point where it's sleep time again?
Okay. That's really a good question, but because there is going to be some, fatigue and some sleep deprivation, and if you're engaged in a very sedentary activity, even the best of us with good sleep, you're going to feel that, and you're going to feel that nodding. So what I have individuals do, I don't have them doing squats all the time, but I do have people getting up and walking, getting a glass of water, doing some light stretching. I have individuals, if and these are easy to use. You get those stretchy bands, and you have them at your desk, and then you do some little exercise with that just to activate yourself. So it's behavioral activation. If you stay there trying to, okay, I got to stay awake for this meeting, I got to stay awake, you're going to fall asleep, or you're going to nod. So you do have to move. And that's what I have people do. I'll also have them do deep breathing exercises throughout the day, not in terms of relaxing per se, but in terms of recentering and also to help with focus.
And so I hope, I'm going to sort of maybe jump a little bit here. If you or your spouse might have obstructive sleep apnea, that's the snoring kind of stop breathing at night, there are a couple things to keep in mind, starting with which sleep center are you going to consult with. You may want to show up and just say, how many minutes of time do I get with the provider to tell my story? I say, well, 6 minutes. Oh, well, okay. Maybe I'll look around. You may want to ask yourself and a prospective sleep medicine doctor, will you talk to me about all the different ways that we could possibly either lessen the obstructive sleep apnea or actually treat it completely and eliminate it? Because, in other words, I think it's important for people who think they might have sleep apnea but are dreading the treatment, need to be reminded that sometimes all we need to do is open up the nasal airway. Maybe they have nasal allergies. Maybe they have a deviated septum. Maybe they have a lot of bloody noses or something. Maybe all they need is an allergy spray, cromolyn, or something reasonably benign. One thing I do not recommend is a vasoconstricting type of nasal spray that you can build up a tolerance to, and then things get worse. But anticholinergics and mast cell stabilizers like cromolyn, for example, and allergy sprays, steroid allergy sprays. So sometimes that's all we need to do. They don't need CPAP. Moving down a little bit on the face, which is where sleep apnea sort of happens, is what about a dental appliance? These are made by dentists who are interested in sleep medicine. They mold them to your teeth, and what they do is, while you're sleeping, it gently holds the lower jaw a little forward, and when the jaw is forward, the tongue, which is the biggest piece of muscle in your mouth, is your tongue. Have you ever seen a cow tongue at the grocery store? You know how huge that is. Well, our tongues aren't that big, but they're still big. And when our tongue relaxes and falls asleep, then every time you breathe in, you suck the back of your tongue in. So having a dental appliance that pulls the jaw forward gently can sometimes make the difference. Likewise, if you combine that with either elevating the head of bed a little bit, now there might be some marital issues there. Most people might want to raise the head of their bed a little bit, I don't know. But raising the head of the bed a little bit just changes how gravity pulls your tongue straight back when you're flat on your back. If you're up a little bit, the tongue can fall down instead of back. That's even more true if you sleep on your side. And so people have to know that there are sleep positioning pillows that make it hard because there's two dips. You can either fall asleep that way or you can fall asleep that way. And sometimes just being tilted up on your side with an open nasal airway, and you've cut your sleep apnea in half. And even if you do need CPAP, you need half the pressure or something. So I think people, patients in general need to face their medical provider with a little bravado and say, hey, I've done some reading here, and I've talked to some people who've had sleep apnea, and it's not like CPAP is just going to happen. And then I want to be told about all of the alternatives. Now, when that conversation takes the next turn, it's about the weight control, and that's really tough. But you might as well, if you're a provider, you're going to have to tell them, you know what, if you could take an inch off of your neck circumference, you'd be a lot better off. And Dr. Degree has experience with this in the community setting. It can be done.
Yep. And it's now 6:30, and we respect our headache yoga instructor is here to do headache yoga, and we want to thank Dr. Czajkowski and Dr. Jones for a great discussion about sleep and headache. So thank you.
Wow.